Hi everyone, good afternoon. I'm Dr. Christina Tennyson, and I'm so excited to talk to you today about gluten, celiac disease, and non-celiac gluten sensitivity. I think these are really important topics for all of us working in gastroenterology to know. And I wanted to thank in particular Barbara Young and Christine Nathan who invited me to speak, and I'm really honored to have the invitation to speak with you all again. So I'm coming to you from Virginia. I live in the Shenandoah Valley outside Charlottesville and excited to talk to you about this. So let's get started. So we're going to be talking about what is it, what is gluten, and why is it so popular? We're going to talk about why is it important, what should you really know about celiac disease and non-celiac gluten sensitivity? And then importantly, what should you do? So how can you really take care of these patients? We'll start today with what is it? Gluten is a complex of insoluble proteins that are found in wheat, rye, and barley. So insoluble means that it doesn't break down in water. And importantly, there's a high content of certain amino acids, glutamine and prolamine, that really make the gluten protein not digestible by our human enzymes. And in our digestive tract, there tends to be these long chains of gluten that can accumulate in our guts. And for most people, it doesn't cause a problem. Now, gluten's been around for a very long time, as has celiac disease and irritable bowel syndrome, but there's been a real increase in interest in gluten over the past 20 years. And this is a really neat graph that circulates really how many times gluten was searched on Google. And you can really plug in any terms that you're curious about. But for this graph, we plugged in gluten, celiac disease, and IBS. And you can see on the lower level here that the amount of interest in celiac disease and IBS didn't really increase, but there's been a dramatic rise and increase in gluten-free diet interest. And what we do know is that there's been a dramatic rise in interest in cutting back or avoiding gluten. And this was according to a study that was done in 2013 that surveyed many thousands of Americans, and they found that about 30% of people were interested in either cutting back or decreasing their amount of gluten intake in the diet. So the Hartman Group is a market research company, and they actually tried to answer this question a little bit more and figure out why exactly are people interested in gluten-free diets. And they surveyed about 1,500 people. The vast majority of the people that they surveyed from all different walks of life and different socioeconomic groups, people really didn't have a good reason for avoiding gluten. There were some people, as you can see on the left side, who thought gluten was a healthier option, who were concerned about their digestive health. They thought it may help them with weight loss, but the vast majority of people had no reason. And all the way on the right side were people who were avoiding it for celiac disease. So what we do know is that this is a huge market. There's a lot of big money involved, and the gluten-free products and gluten-free food market has continued to increase. The data looked like it had about a 12% growth rate from 2018 to 2022. So lots of interest in people eating gluten-free food, and there's a lot of development and marketing by food companies to bring some more of these products out. So there's a lot of interest in gluten-free food, but why is this important? So there are gluten-related health disorders where gluten-free diets are the medical treatment. And that's why gluten-free diets are important. Learning about gluten is important. And we'll talk about celiac disease and non-celiac gluten sensitivity. So gluten-related disorders, I like to think of them as about four conditions that we should know about. Number one, importantly, is something called dermatitis herpetiformis. So if you see a patient, they may have very itchy rash, looks like a chicken pox on the extensor surfaces of their body. So their elbows, their shins, it looks like there's liquid in it. When they scratch it, it can scar over. It's extremely itchy. This is an autoimmune disease triggered by gluten. In addition, there is another condition that affects neurological function, and this is called gluten ataxia. So this is people can actually have difficulty walking. This is related to gluten. And then the two conditions we're going to talk about in more detail today are celiac disease and non-celiac gluten sensitivity. Let's first talk about celiac disease. So for me, this was a condition I honestly didn't learn much about in medical school. I finished medical school about 20 years ago, and this is something we didn't really talk about much. So it's an autoimmune disease. It's triggered by gluten, the protein as we spoke about that's found in wheat, rye, and barley. It's triggered in genetically susceptible people, and it's a multi-system disorder. So it doesn't just affect the gut, but it has many different effects in folks' bodies. So we'll talk about that in a little bit. This is a schematic that breaks down what exactly is going on with celiac disease. So as we mentioned, people have gluten in the diet, and these long proteins are not well digested by our human enzymes because of the different amino acid composition that they have. As we said, there's a lot of prolamine and glutamine. And these dietary proteins, they sneak underneath or actually in between the cells of the intestine. And in here, they actually undergo an enzyme that's called tissue transglutaminase, and it alters the composition and it's presented to our antigen presenting cells, and it causes downstream inflammation and activation of our immune system. So things like CD4 positive lymphocytes, B cells are activated, and you have this downstream damage where the cells of the intestine become inflamed and destroyed. And that's really what we're looking for when we do small bowel biopsies. One of the stereotypes about celiac disease is that it affects people of Northern European ancestry, Southern Europe. But the important thing, and I really challenge you to think this way, is that it's a common worldwide problem. So we know in the US it affects about 1% of our population, and there's evidence from all over the world that celiac disease is present at about that same number, about 1 in 100. So there are studies looking in the UK, in Scandinavia, Turkey, India, the USA, Mexico, and in some of these populations, celiac disease may not be routinely screened. This was a campaign by the National Institutes of Health to get doctors and other healthcare providers to think about celiac disease. And this diagram, it's kind of outdated, but I think it's really very well illustrates that the face of celiac disease can be many different types of people. So people of Asian ancestry, South American ancestry, Caucasian, African American. It's really affects people all over the world. And there's many different symptoms that people have. Oftentimes in people with celiac disease, the real challenge is even just thinking about the diagnosis because the symptoms are so varied and they affect everyone in a different way. So these are accepted indications for celiac disease testing. There's been a group of symptoms that have been lumped together called classic. And really, this is what years ago people were taught, that it can present with malabsorption, with diarrhea, with weight loss, vitamin deficiencies, fatty stool. Also in children, failure to grow can be a symptom. But really, the majority of patients these days present with these non-classical symptoms. And these are the ones that can be really tricky. And when you're doing an intake and endoscopy, if you hear people have these symptoms, it's always good to think about it. So non-classical symptoms include iron deficiency anemia, elevated liver tests, canker sores, or this is aphthous stomatitis, even chronic constipation, ataxia, and these neuropathic symptoms, so numbness and tingling in people's fingers or toes, infertility, early onset osteoporosis, people with recurrent abdominal pain, dental enamel problems, chronic fatigue, bloating. And then folks who are at risk for developing celiac disease are those with type 1 diabetes, dermatitis herpetiformis, that's skin rash as we spoke about, people with autoimmune thyroid disease, people who have relatives with celiac disease, people with microscopic colitis, and then there are other genetic disorders that go along with it, such as Down syndrome, and other folks who have psoriasis, lupus, or autoimmune hepatitis. There could be an increased risk of celiac disease. So important just to think about it. Now, why do we want to think about it? Well, because it's increasing. So we can look at studies that were done previously and compare them to what's going on in the present day. And we see that there's been a dramatic increase in celiac disease. And it's not necessarily related to people eating more gluten because we're actually historically eating less gluten now than what we may have been eating 100 years ago. But when there have been studies done looking at stored blood from Army recruits back in the 1950s, as well as from some older blood samples that were stored in Finland, the number or the amount of celiac disease nowadays has more than doubled. So when we look at the Air Force Base in the US, it actually increased by almost 5 times the amount when compared to current modern day recruits. So we know that celiac disease is definitely on the rise. So why am I saying think about celiac disease? I want you to think about it because we do such a bad job of diagnosing it. This was a study that was done by the Center for Disease Control. It's called the NHANES. And one year they looked at celiac disease. And what they found in this study was that although they did find celiac disease that was a little bit less than 1% of the population, what they found out is that the majority of people with celiac disease, 83% of them didn't know they have it. So there's a lot of people out there who have celiac disease who we haven't diagnosed. And the older numbers suggest that people can wait 10 years before a diagnosis. So we have this kind of paradoxical situation where there's people with celiac disease that are out there. There are people who are on a gluten-free diet out there, but there's many more people on a gluten-free diet than actually have celiac disease. And the majority of people with celiac disease are not on a gluten-free diet. So we're trying to figure out how to, capture these patients, how to diagnose them appropriately. And as a nurse, I think you have a great opportunity to make a big difference by even just thinking about it. So we could talk a long time about diagnosis of celiac disease and a lot of the intricacies of it. So I'll spend a few minutes with some very important points. Number one, there is a screening test. It's called tissue transglutaminase or TTG-IgA. That's really the best screening test we have for celiac disease. It's not perfect like any test we do in medicine, but it's pretty good. People really need to be consistently eating gluten at the time that they're tested. So sometimes I see patients who will come in and say, I ate a bagel yesterday, test me for celiac. It doesn't really work that way. We know that they really have to be eating gluten consistently on a regular basis to mount this antibody response. The diagnosis, upper endoscopy with small bowel biopsy, is still considered the gold standard. In Europe, that is different, where people have a certain amount of antibodies in their blood. The Europeans are actually now advocating for a no biopsy approach, but here in the US, our guidelines have not changed. And there is a genetic test that can be done. It's not a great test as far as genetic tests, but it's testing for HLA-DQ2 and DQ8. And these markers, if they're present, can be helpful in saying someone has the potential for celiac disease, but they're really most helpful when they're negative because they help exclude the diagnosis. So it can be done if the diagnosis is uncertain, if a person has already stopped eating gluten and wants to know if they have the potential for celiac disease, and then also for family members, it can be considered. So you heard me talk about endoscopy and what we should be looking for. When we do an upper endoscopy, there are certain features that may appear with celiac disease. These are actually video capsule images of mine, but I think they really illustrate the patterns very nicely. So number one, you could see a mosaic pattern where you kind of have these little crevices and fissures. Another more classical feature would be scalloping, where it looks like the edge of a scallop shell. Sometimes the folds may be stacked or flattened, and then villus atrophy, so not seeing those beautiful villi, those tiny finger-like projections. What I want you to remember is that in patients with celiac disease, to our naked eye, it may appear normal. So that's why we really have to remember to take those biopsies when we see folks coming in with these possibility of a diagnosis. The sensitivity of these features is really only about 60% to 94%. So we may miss someone who has celiac disease because we don't see these features and we don't take a biopsy. Um, So when we're seeing our patients in endoscopy, the challenge is really to biopsy. The biopsy, even if our endoscopic markers are not there. So typically what's recommended is 4 biopsies from the second part of the small intestine at least, as well as 1 to 2 from the bulb. And those bulb biopsies may be helpful in people who have more mild disease. And when we look at what do our pathologists see under the microscope, this is what celiac disease looks like. So in a normal situation, we have these beautiful, healthy villi, these lovely long finger-like projections with only a few white blood cells. One of the earlier markings can be that there's an increase in white blood cells called intraepithelial lymphocytes. Now, this is something that can be found in other conditions such as H. pylori, people who use nonsteroidal medication, people with obesity. So it's not necessarily something you see just with celiac disease, and you have to be really careful with making a diagnosis just with this type of finding. Some of the later findings include that the glands become enlarged, and this is classically what we're looking for. It's called a Marsh 3, or flattening of the folds. And there's a grading system that can be used. But one thing we know, and this was studied by my former colleague at Columbia University, Ben Lebwall, is that doctors are not really doing a good job. And this is where I think endoscopic nursing staff can play a really important role. Doctors are not doing the biopsies for people who have these even classic indications. So this looked at a CARIS database of thousands of endoscopic biopsies. And Ben looked when patients had symptoms such as diarrhea, iron deficiency anemia, or weight loss, were doctors taking appropriate biopsies of the small bowel? And like 50% of the time doctors did. So there's a lot of opportunity for us to get better at looking for these patients and making that diagnosis. Now I want you to think about it this way: test first and test right. So we want to do the right test, and once people start a gluten-free diet, it does make the diagnosis more difficult for us. So there can be findings on duodenal biopsies that take a long time to heal, months to years, but those antibodies that we were talking about typically do normalize within a year of people starting a gluten-free diet. And you'll hear different things about a gluten challenge, encouraging patients to eat gluten prior to biopsy. And just for time's sake, I don't really have time to go into that too much, but patients should be eating gluten on a consistent basis, several servings a day for a few weeks before. Otherwise, else, if they don't want to do a gluten challenge, I still think it's a reasonable strategy to biopsy the small intestine and see what it looks like. Now, the caveat is these duodenal endoscopic images look really abnormal. These are 2 of my patients who did not have celiac disease. So on the left, this is a drug reaction that can give villus atrophy and flattening. And on the right is eosinophilic gastroenteritis. So not everything that gives you these endoscopic features is celiac disease. And there are lots of causes of villus atrophy, unfortunately. So celiac disease is one of them. Eosinophilic gastroenteritis, as we mentioned, giardia, autoimmune diseases, something called autoimmune enteropathy, tropical sprue, collagenous sprue, Whipple's disease, common variable immunodeficiency is another one, Crohn's disease, lymphoma, radiation, TB. And the one I circled here that I want you to remember are drugs. So drugs can affect the villi, so things like Cellcept or mycophenolate. Olmesartan is a big one. That's a blood pressure pill that can cause terrible villus atrophy and diarrhea. So if you're doing the intake form and you see someone who's using olmesartan and has diarrhea, just remember that they should have their small bowel biopsies done, and it could be the drug, not necessarily celiac disease. So when we talk about celiac disease treatment, the only treatment we have is a strict, lifelong, gluten-free diet. And really, it's done the best when an expert dietitian is consulted. So why is this challenging? Because being on a gluten-free diet is harder than it seems. There are lots of challenges that patients and individuals on gluten-free diets have. Number one, it's lower in fiber. It can also be lower in calcium, different B vitamins. At the same time, it can also be higher in fat, sugar, and calories. And a lot of the packaged or processed foods that people may eat may not be fortified with certain vitamins, such as B vitamins, including folic acid, and as well as thiamine. The cost is prohibitive, and that a loaf of bread can cost 2 or 3 times the amount. And then the potential side effects is that it could have weight gain and constipation. This is a slide that I have borrowed from a dietitian I used to work with, Suzanne Simpson, who taught me so much about celiac disease. And she compared some of the common gluten-free flours that are used in processed foods versus wheat. And wheat actually, when you look across the board, actually has a good amount of fiber. It does have some protein, it has some folate and iron. And some of these highly processed, or we'd call them even ultra processed foods, that are made with tapioca, cornstarch, potato, and white rice are really higher in carbs, they're lower in protein, and lower in fiber, as well as folate and iron. So when we see these patients, and again, the importance of working with a dietitian is that these are really nutritious gluten-free flours that people can eat. So there are things like buckwheat, millet, chickpea, sorghum, amaranth, and quinoa. And one thing that we do know is that avoiding gluten can actually have an adverse effect on people's health. So Ben Lobwall, again, my former colleague from Columbia University, had looked at what happens when people avoid gluten. And they had about 100,000 male and female health professionals that they looked at data. And when gluten intake was reduced, people actually had a decreased intake of whole grains, and those folks were at an increased risk of heart disease. So eating whole grains is important and healthy for our diet, and people who just start a gluten-free diet may not be eating whole grains and lose that benefit. In addition, there are some possible downsides or dangers of a gluten-free diet besides it being higher in calories, higher in fat, lower in fiber, lower in vitamins and minerals. There have been some contaminants that have been present in different gluten-free products. So I don't want to worry you about it, but just know that it exists. There have been reports of arsenic, particularly being a problem in rice flour and rice products. So people were eating multiple servings a day. So it's good in general, as we talked about last year, really diversifying your diet and eating lots of different plant foods. So not just focusing particularly on rice. Okay, so now that we spoke about celiac disease, I wanted to spend some time talking about non-celiac gluten sensitivity. And when we talk about non-celiac gluten sensitivity, I think it's helpful just to clarify some of the definitions that are important. So you may hear of people talking about a food intolerance. The classic example for food intolerance, I think, is lactose intolerance. And it's when the body really lacks a particular enzyme to digest nutrients, or the nutrients can be too abundant to be digested, or you just can't digest it properly. So these would be people who eat lactose, who have ice cream, who have milk, and then importantly, they have GI symptoms. Now, when we move over to food sensitivity, it's a little bit of a different thing. So these are reactions that happen to nutrients, but they're mediated by the immune system. And they don't always occur in the same exact way when you're exposed to a certain nutrient. And it can be GI symptoms, but also extraintestinal symptoms. So not just GI symptoms. So when we speak about non-celiac gluten sensitivity, this is when people have symptoms when they're exposed to gluten. And there may be symptoms that are gastrointestinal. So these could be abdominal pain, diarrhea, constipation, nausea, vomiting, very similar to celiac disease. But patients can also have neurological side effects. So these could be headaches, brain fog, muscle pain, numbness, fatigue, depression. And then other things that can go along with it include rashes and nausea. So how do we define non-celiac gluten sensitivity? It's something that I would argue is currently being worked on actively. It's a clinical condition. It's caused by ingesting gluten. And as I mentioned, it has intestinal or GI symptoms as well as extra intestinal symptoms. And in these patients, you have to be very careful that you have excluded celiac disease and excluded a wheat allergy. So what do we know about it? There's so much that's unknown. So non-celiac gluten sensitivity, we don't really know how common it is. So celiac disease affects 1% of the population. We don't really know how common this is. The symptoms can be variable. So they can occur in hours to days after. There's no great genetic marker. There's no great testing or blood test that can be done yet. The small bowel biopsies should be normal. We don't really know that there's any increased risk of malignancy, cancer, osteoporosis, and we don't really have a great way to test for it. And we don't know how long these symptoms actually last. So a lot more is unknown than known. And the next question comes, is it really irritable bowel syndrome? So we think it's not irritable bowel syndrome because there's different symptoms. Again, it's not just GI symptoms. And people often ask, if a patient has irritable bowel, do they do better on a gluten-free diet? So there were some older studies that weren't really very well done that suggested that. But however, when it's been studied more recently, it doesn't really seem to be that gluten has effect on the vast majority of people with irritable bowel syndrome, so it's not recommended. And we get to the next, area, the cutting edge area that says, really, is it the gluten or is it something else? So there are other things called FODMAPs, which are these long chains of carbohydrates that our body doesn't digest, including fructose, oligosaccharides, polyols, which are sugar alcohols. And there's also something called amylase trypsin inhibitors that are that are proteins that are found normally in wheat that actually have an effect in protecting the plant itself against parasites and mealworms. So there are patients who may not have symptoms when they're given gluten, but this potentially may be what's going on, that it's not necessarily the gluten, but it may be something that's in the wheat itself. And there's really an increased interest in looking at biomarkers to help diagnose these patients, to help work it out. This is a systematic review that was performed and looked at the effect of a gluten-free diet on irritable bowel syndrome. And really, there's insufficient evidence currently. This is a pretty new study from 2018 to recommend a gluten-free diet for IBS. And this was a study done by the group, Peter Gibson's group from Australia. He's done a lot of work on gluten sensitivity and FODMAPs. And what they found is that it didn't seem gluten itself had an effect, but it was the FODMAPs. So these long chains of carbohydrates that are found, wheat is one of them. So that seemed to have more of a predominant effect. And people were given a challenge where they were given gluten or a placebo while they were eating a diet consisting of different FODMAPs. So moving on, what should you do? How can you help take care of your patients? One thing that I'll argue again, and I'm sorry if I'm saying it over and over, is really just to think about celiac disease. The physicians you're working with, the referring doctors may not have. I think as seeing these patients, this is such an important role that you can play, is just to think about it. And how do we take care of them? Number one, I think the important thing is education. So educating yourself, your colleagues about celiac disease, learning how to diagnose it, how to prevent deficiencies for people who have celiac disease or may also be on a gluten-free diet for other reasons, trying to encourage them to eat whole foods, to eat less processed foods, and be cautious in limiting gluten for other reasons. So while we're evaluating these patients, a question that comes up, and I just wanted to address it quickly, is how do you assess them? So there's really not any great universal agreement on what to do. Typically at visits, patients have their height, their weight, their BMI calculated. Blood tests can be performed to check their blood counts for anemia, their liver test, different vitamins such as vitamin D, B12, folate, fat-soluble vitamins, also including A and E in addition to D. Also checking for micronutrients, so things like iron, magnesium, phosphorus, copper, zinc. Checking antibodies. So for these patients, I typically will check in once a year. And then really getting a diet assessment, trying to figure out what they're eating. Often patients will be eating the same things over and over again. And then reviewing their medications, their vitamins, their supplements, getting a bone density test, and doing a good history and physical. I wanted to encourage you to think about joining. It's called the SSCD, or it's the Society for the Study of Celiac Disease. Their website, you can see here, is the celiacsociety.org, and it's an organization for doctors, nurses, researchers, dietitians, anyone who's a healthcare professional interested in celiac disease. And they run lots of great workshops and educational resources. And lastly, kind of what's the future? So there are therapies that are in the pipeline. I always think of celiac disease as a condition where we don't have drug companies going around giving lunches, doing continuing medical education. So it's almost an orphan disease in a way. There's not a lot of money that's being poured into celiac disease education. And that may change because there are treatments that are being looked at. And a lot of these treatments, I think about them in three separate ways. Number one is reducing the exposure to gluten in people's diets, reducing permeability, so making the cells of the intestine closer together, reducing activation of the immune system. So there's lots of different targets that are being looked at currently. Take-home points. I wanted to stress that there is a rise in the interest in gluten-free diets. Think about celiac disease and making the diagnosis. Gluten or wheat sensitivity does appear to be different from irritable bowel syndrome. And there are maybe other components besides gluten that can be important for non-celiac gluten sensitivity. And working with a dietitian is always very helpful. And with that, I wanted to close. I left my contact information. It's catennyson@augustahealth.com. I also put some of my social media handles on here, although I haven't been as active lately. The Instagram is Lifestyle Gastro MD. So thanks so much, and I really appreciate your time. And please contact me if you have any questions. I'm happy to talk about it.